Hi everyone, welcome to the SNF Consolidated Billing Facility Services. SNF stands for Skilled Nursing Facility, and this is the consolidated billing class for facility services. My name is Tom Ryan, I'll be your presenter today, and I'm with Provider Outreach and Education at WPS. I'm also joined by Karen Curtis, who's a friend and a colleague of mine. Her job is to watch for those questions coming in chat, answer anything she can, give you some different resources as we go through. Also, there were questions presented in advance, so I'm going to have her add some different resources related to those. So they may not be in the presentation because I didn't know you had those questions necessarily, but in reviewing this morning, I did find that we had a bunch more questions submitted, and I want to make sure to address those. All right. A couple of housekeeping things you'll want to be aware of. First, if you want the presentation that I'm about to go through, please go to the Training Center to the live events page. Karen's going to put a direct link to the live events page. What you can do is go ahead and download the presentation from that page. I will let you know that I anticipate that presentation being up either through the end of the day or tomorrow morning, and then it will be removed. However, that doesn't mean it's not available. Here's how that's going to become available. We're going to record this, which you heard me say we're recording it. What we'll do is we'll put it as an encore presentation. With that encore presentation, we will offer, again, the exact same PowerPoint. Don't download it again if you already have it. There's no reason to do that. However, it will be available for 60 to 90 days. The encore presentation will be available on our website. And, there will be a player there from YouTube that you can watch. Also, the encore presentation will remain available, which is the actual recording in YouTube, until such time as the content changes or we choose to redo this content. So keep that in mind. It's typically on our website for about 60 to 90 days. For this presentation today, I did take pre-submitted questions and I do have a variety of points worked in to make sure we get through that. However, I will take questions in the chat feature and we will answer those as well. So please put your questions in the chat, put them as they come to your head and as you get through that information. We want to make sure that you don't miss anything. And in order to do that, we ask that you do it right away. After this, you will be offered a survey. It's going to look like a typical survey link, but I'll explain more about how you're going to get it in the different resources. One, it's going to be through the chat feature. Two, it's going to be through the actual closing. We'll show the pop-up. And then three, it'll be in the email. The survey helps us, and so we really are going to encourage you to take that survey, but I want you to be aware that it's coming and that you should try to take it if you can, but you don't have to. All right. Sorry, there we go. My computer is acting a little weird there. Karen, can you see the disclaimer slide?
Yes, you're
Okay.
good.
So the disclaimer, just to give you a couple of pieces of information, as anyone that's been with Medicare for any period of time knows, Medicare can change. So I did verify again this morning. I pulled some information this morning and checked it. Our information that we have for you is current as of this morning. So right now, the slide deck is dated and it is dated with this month and year. However, the information can change and we all know that. So any answer that I give you today and any the information in this presentation is just a tool to assist you with education and provider community. However, if the information changes, you do have to keep track of that. And we do recommend going to the CMS website. I will tell you that there is one question that was asked repeatedly, and that's where are the current updates for these lists and where's the current updated information. And I will show that to you on the CMS website later. So it's important that you do keep track of that information. It can directly affect what is billed and what is not billed to Medicare versus the skilled nursing facility, which of course is our agenda for today. We want to look for, from the facility standpoint, when should you bill the SNF versus Medicare? We want to avoid the denials and the takebacks that seem to happen. Now, we understand that we're not going to be able to avoid all of them. I don't think anyone in Medicare is, going to say, oh, yeah, we should do that all the time. There are times when we look at it, we know the data is going to show this. We want to reduce that as much as we can. And so again, the data does show that this is an issue, and the data does show that consolidated billing is something that needs to be addressed. And we'll talk more about that. So we will explain the basics of skilled nursing facility consolidated billing, or SNF CB. You'll hear me refer to it as both. I might just say consolidated billing throughout the course. I use a variety of different terms. If I use an acronym you are not familiar with, I will have you put that into the chat right away. We'll get those addressed as quickly as possible. Once we explain the basics, we're going to move to which facilities and services are subject to SNF consolidated billing. So which ones do we have to look at? What are the facilities and what are the services? Then we're going to show you how to determine, based on the CMS website, what to use. What tool helps you determine the procedure codes that are subject within those facilities and those services. Because it is a procedure code driven and there are some place of service criteria that we have to talk about. And so we want to show you all of that. That is our goal and our agenda today. I do want to remind everyone that we do not write CPT and we do not write any of those types of pieces of information. This course does use CPT procedure codes. It also will use some HCPCS codes possibly. So if you stay on, you are agreeing to the CPT copyright notice as written by the AMA. If you do not agree to this copyright notice, please disconnect at this time. Okay, one of the first questions that we had right away is, I'm new to Medicare. What do I need to know about this topic? That's what this question or this section is designed for. Now, I will say it's one question. It really wasn't one question. I actually have 6 of you that submitted something similar to being relatively new, and I want to make sure that I don't lose you in the process. So I will stop after this section and take questions. Again, I want to make sure that I'm explaining everything in a manner that helps those people that are new, that don't really have that basic understanding, get that basic understanding. Otherwise, the rest of this course will not make sense. All right. Now, I will let you know too that we did do a presentation, and it is just the basics of SNF consolidated billing. I'm going to give you some highlights with the slides. However, if you really are looking for that course, I would recommend going to our SNF consolidated billing playlist. Check it out. If you want that, I can have Karen go out and look that up and put that playlist for you directly into the chat feature. But in the meantime, we'll go ahead and get started. The first item that you want to be aware of, when we talk about SNF consolidated billing, what is it? And it is a form of a bundling payment system for Medicare. Now, what that means is that SNFs, skilled nursing facilities, are paid a prospective payment system. That's how they're paid. That payment system incorporates all items and services into one payment. That's why consolidated billing occurs. So it's one payment for all included services during a Part A covered inpatient stay. Wow, that was a lot. So we're going to move through some of those different criteria. One of the key things that people have to understand is Part A covered inpatient stay. That simply means that Medicare Part A is paying for that stay. Because Medicare Part A only offers 100 covered days of skilled nursing care within a benefit period. Benefit period simply means they were not inpatient anywhere for 60 days or more. If that happens, a new benefit period will begin. So it's 100 days. Do they have to use 100 days? No. If they use 20 days and then they have an over 60-day lapse, it'll start a new benefit period. It's 100 days. Now, the Part A portion says, well, what if we get above 100 days? All of a sudden, they're still in a medically necessary stay. What is that called, or what is that? Many times it's referred to as a Part B stay, which indicates they're still inpatient. It's still medically necessary. Only Medicare Part A, the facility portion, is not covered. We'll go back and forth with that a little bit, and I'll hopefully be able to explain that a little bit more. Another portion that goes with the SNF bundling, the Skilled Nursing Facility Consolidated Billing bundling concept, is that it has to be within the SNF's scope of practice. And so there are certain procedures that CMS says, look, we don't expect a skilled nursing facility to have this, or we don't expect a skilled nursing facility to be able to do this. An example of that would be some of the surgical codes. So there are minor surgeries that, yes, it is safe to perform in a SNF, and we are good with that. But there are some complicated surgeries that we do not believe the SNF should be performing. Now, the SNF we being Medicare overall. And so that's what the list that we're going to go through will help us determine. Also, as we look at the Part A stay, there are criteria that must be met. And I should have explained this, and I didn't, and I apologize. There is what is called a 3-day inpatient qualifying stay, or a 3-day covered stay. It just depends on how you use the term. and that is the day of admission into a hospital, the next day, the following day, and the day of discharge, because the day of discharge does not count as a payment day, so they get 3 days. I like to refer to it better as a 3 midnights. You have to be in at midnight to get paid for that day, therefore it's 3 days. Key thing there, inpatient. One of the questions that was asked that goes with this bundling concept is, does an outpatient stay, they use the term observation stay, which is correct, it's an observation stay, does that count as part of that 3 qualifying day stay? And the answer is no, it does not. So when we look at this bundling concept, there are a variety of factors that must be applied. First, Part A has to be paying, which means a 3-day qualifying stay has to occur and they have to be within the first 100 days of that benefit period. And the service has to be in the SNF's scope. And that's defined by procedure code. That's what we're going to look a little bit more. The next concept for the actual bundling concept is the 2 types of stays, which we already went through. Sorry, I'm not sure why it's doing that. There we go. Is the 2 types of stay. And you heard me refer to this, but I wanted to really drive this home because there was 3 questions that asked about what happens after the 100 days. And I wasn't really sure with that 100 days what you were referencing. So let's talk about these 2 types of stays. Medicare uses Part A stay to indicate that it's during the 100 days of the SNF benefit period. Medicare Part A is paying the facility portion, which includes room and board, nursing care, and most skilled services, such as rehabilitation therapy services and things like social work services. However, it excludes most of the professional services. Now, again, why? Well, physical, occupational, and speech and language pathology are professional services, but they are included. So that's why we use the term most professional services. Medicare does offer 100 days during a benefit period. These days are then used up, and a benefit period can be more than once in a year or only once in a lifetime. The question that came in for that was that they have a person who meets the tube feeder requirements and is never leaving the skilled care because they're meeting those requirements. And does that person's benefits stay renew after any given time? And my answer to you is no. If they're meeting the tube feeder requirements to stay on a medically necessary stay, they will have 1 benefit period for their entire lifetime. Therefore, the Part A stay doesn't apply, in which case the Part B stay concept applies. The Part B stay concept, again, Medicare is not covering the inpatient care. However, we are still able to pay anything that Medicare Part B outpatient services would cover. Though they're inpatient, if we would cover it as a Part B service, Medicare will still pay it, even though they're in a medically necessary inpatient stay. That's a Part B stay. So that's why some people don't understand the 2 and they get a little confused over it. With that said, Part B stays are common when the coverage criteria for a 3-day qualifying stay is not met or after the 100 days are exhausted. Now, one thing that someone asked that I did want to address with this Part B stay, does it automatically move to a Part B stay when the patient comes back in and they have not had the 60 days? The answer is no. You get 100 covered days and it doesn't have to be consecutive days. So if you go into the hospital and you have a 3-day qualifying stay, you then leave and go to a skilled nursing facility for 45 days. That's only 45 days worth of use. You're then discharged, sent home. 6 days later, you fall and break your hip, so you go back into the hospital. You now have emergency surgery, and then you have to go back to the SNF. So you're in the hospital for a week and a half. You then go back to the SNF for some rehabilitation because you have a broken hip and you need to go through PTOT. That is 1 continual 100-day stay because there is no 60 calendar days, no 60 days in between the 2 stays. So we already have some days used and they don't get the full 100 days again. At the same time, if they remain in there over 100 days and then they have a small lapse and go back in, there we still stay within the 100 days. Hopefully all of that makes sense with the questions that were asked, and I tried to get to all of those different questions and kind of lump them together. If you have more questions on those, please feel free to put those into the into the chat. We'll get those answered for you in just a moment here. We were asked a little bit about SNF billing. Now, I will tell you, this is not a skilled nursing facility billing course. And the reason for that is consolidated billing is not about how you bill to Medicare if you are a SNF. Instead, consolidated billing is about the concept that says another provider should bill the skilled nursing facility. And that is what we're going to talk about today. Okay, so keep in mind, a skilled nursing facility must bill if the patient remains in a skilled stay. They can send monthly bills. They can send a discharge bill. That's fine. They can also send no pay bills to indicate they're still in that monthly stay. They're still in that medically necessary stay. What happens though is during the time that Part A coverage is being done, each bill must come in a chronological order, and one bill must process before the next. So January comes in and must process before February. February comes in and must process before March, all the way down the line. If at any given time late charges come in, this can affect the processing and order. So think about that with consolidated billing, where the SNF is suddenly getting a bill from outside an entity. They now have to go back and adjust their payment, and it's the middle of February, and they're adjusting the January charges. Or maybe it's the end of February. Well, they can't bill February until that process is through, and that adjustment can take time depending on what the adjustment is for. So sometimes within our system, we do not show that they are in a skilled nursing facility yet. So January they were admitted, January bill gets sent out, let's say January 1st, just for ease, they were admitted. The January 1st to 31st bill is sent out. This is your admission bill, but it's not sent out until February 10th. Okay, that's a 10-day billing cycle. That's perfectly fine. It indicates to us that they're still admitted. However, we haven't processed that yet. We have 14 days before we finalize that. In the in-between time, the SNF gets something else in. What's that something else? It's something from an outside provider that during January they had this happen. Now they go back in and adjust their claim. That can change the processing days. It could actually cause it to be delayed a little bit. Or it could have just processed and now they have to go back in and do an adjustment. That can change the processing days. So now all of a sudden we're into March and April and they're still waiting on January. Well, then they can't bill February and March. So your claims as an external provider can be affected in that we don't even know yet that they're in a skilled nursing facility stay and that this is considered a covered stay and whether or not it should be. Because keep in mind, even if the patient is in a Part B stay, the SNF does bill us. They do, it's called an informational claim. So they want to keep that kind of information going to us. So I wanted people to be aware of that because the question was, why do I get a take back after I've already been paid and suddenly they're saying, no, they were in a SNF for that. Well, so think about it. If you do something in January and you did it January 1st, maybe January 2nd, even the 20th, you bill us. You can bill us later that day. You can bill us the next day. That's fine. That's normal. It's an outpatient service. We're good with that. The outpatient service comes in, we process it and pay it. All of a sudden now it's the middle of February and the skilled nursing facility is submitting their inpatient claim, and this is an effective service that will auto-generate an overpayment. So I thought I would explain that a little bit to help understand a little bit about those auto-generated overpayments. So skilled nursing facilities can be reimbursed for Part A and B services. This means inpatient and outpatient services. This is why consolidated billing can be quite confusing for some people. Their reimbursement does incorporate both of these sets of services. Let me give you an example. While the patient is in a Part A stay, only the skilled nursing facility can bill for preventive care, which is a Part B service. So with that, you have to bill. Now, it's not part of their prospective pay system, but they're the only ones that can bill for it. So hopefully that then helps you understand a little bit more related to the other questions that we have so far. With that, however, we do come to our first set of questions. Oops. Oh, sorry. I did miss one slide here. Excluded services. There's some questions that came up definitely about this, and I just wanted to bring this one up. When we use the term excluded services, there are two types of excluded services. The first one is Medicare excluded services, which are never ever covered by Medicare, nor should they be billed to the SNF. The SNF cannot bill them to Medicare. They will not be paid by Medicare for them. It is an excluded service. The second type is skilled nursing facility consolidated billing excluded services. This one is a bit different in that when we look at this particular excluded service, I'm only talking about excluding from billing the SNF. It's excluded from that prospective payment system. So I will commonly use the term excluded service. I'm using the second reference. The first one is only used if I specify this is a Medicare excluded service. Remember, Medicare excluded services will not be covered by Medicare, and regardless of whether or not the patient is in a skilled nursing facility, must be billed to the patient. It just is the way that it works for a Medicare program. It's not a covered benefit. A skilled nursing facility consolidated billing service, if it is excluded from the consolidated billing or the bundling portion, then the SNF is not responsible and you bill Medicare. And that's the difference. Now, Medicare will consider it based on all of the other coverage criteria. Let's jump to that first set of questions. Again, this question is based in, they're looking for how to bill those non-covered charges. And again, we can't answer that. First, the SNF bills them in a certain manner, and that's in their billing courses. Second, if you're not a skilled nursing facility and you're trying to bill them to the SNF should be denying them. They're not covered. They're not part of the Medicare program. On the other hand, they should be billed to the patient. So a variety of different things. I would recommend that if you are taking a look for anything and you want something that might help you, take a look at the skilled nursing facility playlist in YouTube. This has got some billing courses that are specific to skilled nursing facility. So it's not about consolidated billing. It's about how the SNF bills the claim and puts it together. So I'm guessing that's what you needed. If not, throw that back in chat, help me out a little bit more. Karen, did we have any questions in the chat?
Tom, we have not had any questions come through yet.
All right, so with that, I'm going to assume that got you guys what you needed for that overview portion for those that are new. The next thing that we do want to talk about is, because this is a prospective payment system or a bundling concept, we need to know which facilities are affected by this bundling concept and which facilities are not. So that's what we're going to focus on next. The big question that we commonly get is, should I bill Medicare, the SNF, or the patient? Now, again, you should bill the patient should they have a patient liability or it's an excluded service. Should you bill Medicare or the SNF? And that's where it gets confusing. So that's where we have to start determining coverage. Okay, where we need to start with our determining of coverage. So start by determining if a service is medically necessary. If it is not medically necessary, there is a form called the Advanced Beneficiary Notice that can be given to a SNF patient to explain it's not medically necessary, therefore you're going to be responsible. Also, determine if it is an excluded service. If it's either one of those two, stop. Make sure that you've given the form, do that. If it's an excluded service, you don't even have to do that. Just make sure that you know it's excluded. However, if it is not one of those two, next you need to determine the procedure code. Now, someone asked, why do I need to determine the procedure code? And the answer is the procedure code will drive whether it's considered part of the prospective payment system payment. So whether it should be billed to the SNF or to Medicare. So you have to determine the procedure code at the destination. Then Medicare goes on to say, okay, if you've determined the procedure code, and the procedure code is a rehabilitation service, they define this as a physical therapy, occupational therapy, or speech language pathology service, or any of those services listed that could be performed by like a physical therapist, but a doctor is performing them still within their state scope of practice, those services must be billed to the SNF. That's what the skilled nursing facility is being paid for. So once you've determined that they're covered, they're medically necessary, etc., Then if they're performed, they have to be billed to the SNF because that's part of what they're paid for. And there is a file that will tell you by procedure code which ones must be billed back to the SNF. And if it's not part of that, then you have to make sure that you're getting those services done correctly. Okay. So part of the prospective payment system says, hey, as the skilled nursing facility, you are responsible for outpatient rehab services. Here's that list. This is what they're there for. I'm sorry, you're responsible for inpatient rehab services, more intense than outpatient rehab, and this is what they're responsible for. The next one, a couple people had questions on, and it's the affected services. So the first one I think is where some of the questions or comments came from, because many people said, well, how does this affect the physician? Now, again, I just explained, if a physician does something that meets the definition under the physical therapy, occupational therapy, or speech language pathology, those could have to be billed to the SNF. That's one way. But also, physicians bill what's called a place of service. Hopefully you guys are familiar with this concept. The place of service changes from a Part A to a Part B stay. So that means that sometimes the physician will receive the facility side because the facility is not getting paid for it. That's a Part B stay. And other times they will not receive that facility reimbursement. That's a Part A stay. So depending on what the patient's inpatient status is, the physicians are directly affected. Contracted therapists, that's again what we just talked about. Hospital swing beds. The overall concept does apply to hospital swing beds and consolidated billing. Not exactly the same when it comes to billing, but the concept applies. Imaging centers. And I think this question, and the reason I put this one in here is because they were talking about an MRI in particular. So I thought, okay, and they're going to a freestanding MRI, and then they're sending other patients to a hospital MRI. So they're sending them to this freestanding, and if the freestanding doesn't have the space, then they use the hospital. And so they're like, well, sometimes it's included and sometimes it's not. I will explain that. Freestanding is always the SNF's responsibility. Hospitals are excluded based on the definition, and we'll get into that definition and things like that in just a little while. Now, ambulance suppliers, this is one of the most interesting ones. I'm going to teach a whole separate class on this. So if you are an ambulance supplier, know this is a high level, quick, fast, down and dirty explanation. It's definitely not everything you need to know. Basically, we're going to look at the service at the end, and if the service is included in the prospective payment system, it's part of the bundling, then the ambulance run to that service is considered part of the service and therefore part of the bundling. On the other hand, if the ambulance if the service is excluded, such as services done in an emergency room that are billed as emergency services, then the ambulance run to that emergency room is excluded as well and is separately billable to Medicare. Very simple high-level explanation. We'll get a little bit more into that if you have questions on it. And hospitals. Again, a hospital that has any kind of acute care could be affected. The 3-day qualifying stay does not have to have occurred in a critical access hospital, an acute care hospital. Somebody asked, well, what if it's an inpatient psychiatric facility? What if it's all of those different types of hospitals, long-term care hospitals? These are all hospitals. So they may have different names, even incorporating the name facility, but they're still going to qualify for that 3-day qualifying stay as long as the patient goes in within 30 days and is admitted to the SNF within 30 days. And again, there's some exceptions to that too, as always. So if you want those exceptions, we'll talk about those. This is not an all-inclusive list, and really one of the driving factors is that I put the questions or these affected providers in because they are what you ask questions on. That's what I chose these providers for. Someone did ask, are there certain providers that are not affected? And I will tell you yes, and it's based in their payment system. In particular, the question was about rural providers. Now, I wasn't sure which type of rural provider you are, whether you're a critical access hospital swing bed, which is its own separate payment methodology, whether you're a rural healthcare clinic or a federally qualified healthcare center, which all of those can occur in rural areas. So I really didn't know that, and you didn't have that information for me. So again, it's not affected. If you're any of those, you are not affected. their payment methodology is such that it doesn't affect consolidated billing. They would have a different set of method, or a different set of payment methodologies. Medicare excluded services are never affected by this. If it is an excluded service, as I explained early, Medicare excluded services are always billed to the patient. Make a note, highlight that. I don't know how many questions I got on that, but there was a couple of different questions, and I really want people to understand. If it is not part of the Medicare program, it is never the SNF's responsibility to pay. The other types of not affected services are the ones that are on that list of services on the CMS website. That's our next section. We will get to that. If it's on that list of services, it is not something that is affected by consolidated billing. It's excluded from it. One of the questions we got is, does consolidated billing affect how we bill Medicare? Well, it affects whether or not you bill Medicare, not how you bill Medicare. If the service is not part of consolidated billing, it still has to be billed the way that you would bill any other service. That could be on a 1500 or UB04. That could be an 837I or an 837P. And you have to follow all the billing criteria that go with that type of claim submission. It doesn't change just because the patient was inpatient in a SNF, except for maybe like place of service for a hospital or place of service for a SNF. Now a hospital would be a swing bed. So yeah, some of that stuff gets a little different in there, but the actual billing component is not affected. It's not how you bill. It's if you bill. Which brings us to the billing guidelines. The billing guidelines for a skilled nursing facility can be different than some providers bill. Well, this is because they bill on a different claim form or electronic submission. We were asked many times, are you going to cover the guidelines for what I should bill to the SNF? And the answer is no. We're not going to physically go through and say, the SNF needs to get this, 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 and this. Many SNFs handle this differently. They may require you to have different pieces of information. My comparison for this is for those of you that are familiar with Medicare Advantage or Part C plans, and we say to you, you have to contact that Part C plan to see how to bill them. It is the same thing when a service is subjected to the bundling portion of SNF consolidated billing. The SNF needs certain pieces of information or they cannot bill it. The SNF is also responsible for maintaining documentation to show that that service is medically necessary and should be on their claim. So if they get audited, we can ask them to give those documentation to us, and that documentation could include a service that you are billing them for. If they do not have the documentation, they could be found to be billing it wrong, which can directly affect their payment. So keep in mind, all of those things can occur back and forth. So when you're billing the SNF, follow their guidelines for billing. If they have certain things they need, provide that to them. If you're billing Medicare, then follow the Medicare guidelines. They didn't change just because this person was inpatient in a SNF and this service is excluded from SNF consolidated billing. They did not change. It's the same basic Medicare guidelines. Yes, that does mean that Medicare secondary payer rules apply. And yes, that does mean that the advanced beneficiary notice of non-coverage could apply as well. So those are two very specific questions. And if you want more information on that, put it in the chat. I'm going to try to leave it at that and see where we go because the questions were just if they applied. Here's how I'm going to handle this section. Again, Karen's going to throw some information or going to be available to you guys for chat. I will have you put questions in chat. I'm going to go through a couple of pre-submitted questions and we'll go through chat again. So one of the primary questions we got is, does the SNF have to have a certain type of bill? Now, I'm assuming by type of bill, you're referencing the UB804 or the 837I transaction. Type of bill is a field indicator on there. And it usually is, well, it's 4 digits, but the first one's always a leading 0. Then it represents facility, things like that. And the answer is no, they may not. They may, on the other hand, accept something that comes in on a 1500 claim form. They may be able to accept an invoice, something along those lines. It's really up to them to determine what they're looking for. Ultimately, the SNF billing will reflect the type of bill for that patient for that data service, and it's the SNF bill that's submitted to Medicare. If I was off base on that question, please put that back in chat. I don't know what you were talking about, what type of bill in that case. So I'm speculating my question there. What information does a SNF require? This is a great question, and we kind of talked a little bit about it, but let's hit it super in depth. The SNF requires all information for billing. At the basis, this means the patient's name, date of birth, all of the basic patient demographic information. Well, that makes sense because if they have to verify who it is and they have to be able to show Medicare that this information that you're submitting them and that they're putting on their bill belongs to that patient. So this belongs to that, okay? Along with that, they have to have anything to support medical necessity. So what supports medical necessity? Documentation. So when the SNF says, I need your documentation, it isn't a violation of HIPAA to share that with them because you're billing them and they want to be paid. Is it a violation of HIPAA when you do a prior authorization or when you do medical review with Medicare? It's the same concept. So that was another portion of a question that came with it. So yes, you can share documentation with them. When you do that, could you redact the record? That's up to you. I can't answer a redaction question because I'm not sure what you're trying to redact out. So please just be aware of it. Medicare will not approach the person billing the SNF for medical records. It always goes directly to the SNF for medical records. So when we look at it, because they're responsible for the payment, they're responsible for gathering any medical records. If there is an excluded item, yes, you can bill Medicare for that. The SNF does not require a record for that of any kind because they're not billing that. You should bill directly for that. So when you come to those excluded items, and remember when we say excluded in this case, I'm talking Medicare program exclusion, under the law, whatever. And yes, you want to follow the correct billing for that. Could be a condition code, could be the current, I think it's a condition code or a modifier. But please keep in mind, yes, those need to be followed when you're billing for that. The SNF does not need to be informed when you are billing an excluded service. They're not responsible for it. Now, if you have a state contract and you are required to inform them based on that contract, I'm sorry, it's not a state contract, it's a legal contract. If you have that legal contract, then yeah, you have to follow that information, okay? So it's a couple of things to understand there. The last question I have for this section that was pre-submitted is, does the skilled nursing facility need to reimburse me at the Medicare allowed amount? The answer is no. They need to follow a couple of different things. One, if you have a contract with them, obviously that's a legal binding contract, so follow the contract for reimbursement, whatever that happens to be. Two, if you do not have a contract for them and you're just billing them, you have the right to ask for the full payment, not the Medicare allowed amount. That's not it. There's no contract saying you have to take a lesser amount. They do have to pay you based on the conditions of payment. And we do have that link coming up probably in a little while here. But the conditions of payment is part of the Code of Federal Regulations that specifies all the things you have to do to be considered part of Medicare. Now, Medicare is not involved, or WPS is not involved in those disputes. That's something that you would have to go to regional office or central office or any of those types of locations. We cannot handle anything related to that. With that said, Karen, do we have any questions?
We do not have any questions in the chat.
Okay, let's keep going here. Now the next is the billing area, and this is where we have to determine where each procedure code should be built, whether it's the skilled nursing facility or Medicare. I put 6 different questions together to kind of develop this. So like, when do I bill a SNF versus Medicare? How to determine what services should be related to the SNF. So if I don't hit your question and you submitted it and you feel like it should fall into this area, please feel free to ask me. I'm going to tell you that I'm going to move to the website live and do some live navigation. However, what I'm going to try to do is follow the slides that I built for you. Well, I'm not going to try to. I am going to follow the slides. You will have slide pictures to help you through. I'm going to use the live website portion. So what I'm going to do is just jump through the next set of slides that I'm going to present on. Don't worry if you're like, wait, he's going through slides and he hasn't talked about them. I know that. I'm just trying to prepare a little bit for when we get done with this and I can come back. All right, so here we go. So first of all, the website that you'll need to be on, and this is going to be on slide 23, is just the CMS website. It's cms.gov, cms.gov. So www.cms.gov. When you're looking for these lists, it is under the word Medicare. Okay. When we go to Medicare, you're going to have a drop down, and I want you to go to coding and billing. By selecting coding and billing, you're going to see the list on the right side change. If you go all the way to the right column, you'll see skilled nursing facility consolidated billing. That's what we're talking about. Remember, that's what the bundling name is consolidated billing. By selecting that, it opens up our very own explanation page. You are welcome to read this explanation page. I'm not going to do that for you because I already went through most of it. If you look at the left side, however, you will see that it starts with some Part B MAC updates. This is for Part B stays or Part B services. What's defined as a Part B service? Preventive, professional. Okay, that is not what we're focusing on. We're going to focus on facilities, which for the most part are going to be down in the Part A MAC update. Okay, now if you want to go ahead and view this, I always recommend that you look for changes that have occurred since this file was published. How do you do that? Click on the most current set and then look. It's going to tell you, hey, wait a minute, here's some information you need. Here's some information you need. A couple of you asked me about the updates and the changes. In particular, one person gave me a procedure code and I need to get down to major category 4 because it's right here. So they're like, it's not on this list. Well, I understand that. However, it is on this update list. So by the time that we get into that list, we should have already read these updates. So if you download the list, which is at the bottom, and I'm just going to scroll down. If you download this list, these changes, including additions and terminations, are not going to be listed there. So please be aware of that. The next thing that I would like to do is to just briefly talk about the different files because there is more than one file. So the Part A MAC update does contain 5 different files, major categories, in other words. Now it's all in one big Excel technical spreadsheet, but we have 5 different parts of it. That is explained in this first file, I'm sorry, in the second file, which is purple on my screen. It'll say PDF, the last 3 is PDF. This is just the explanation. It is not the file, okay? So I'm going to show you this explanation. We're going to take a look at the file in conjunction to kind of help you move back and forth. So before I open the explanation, I do want to just pull up this. So if I select it, it's going to ask me to unzip the file. All right, I've done that in advance so that we don't get stalled out here. It's going to give me 2 different options. The first one is an Excel file. The second one is a CSV file. It's a form of Excel. It's just the 5-way compliant one. I opened the first one, which looks like this. You got a procedure code. You got a short description for that procedure code. If you're wondering, this would be a modifier, TC26, something like that. Then you've got a major category and it will tell you. Well, this is where most people get confused because what does major category 1 mean? What do I need to know about that? That's where you need to go back to the website and you're going to open up the PDF, which is the second one. So if you don't know what a major category 1 is, let's start there. If you don't know what the subcategories are, we'll get into that as well. When we open this up, you can see that the major categories, ooh, whoa. Sorry, that got really big. Okay. Karen, can you see that in like a reasonable size font now?
Yeah, it looks good, Tom. Thank you.
Okay. Y'all can see, obviously, my scroll mouse is going a little crazy today, which is why all this stuff is happening. But this will explain to you the 5 major categories and then the information you need under each major category. So such as a subcategory of services, okay? So first is major category 1. These are services that SNF cannot perform. They can't perform it, it's excluded. However, don't forget to read on to this first paragraph that explains more about this. It says based at a hospital, including a critical access hospital only, they're excluded. This is key. Okay. If it's not, and it's in this list, and it's done at a freestanding diagnostic facility, not related to a hospital, partially owned or operated, any of those criteria, guess what? It is part of consolidated billing. This is the one question that I had where they asked me about an MRI. It's right here. It's going to be in C. And I didn't know the actual procedure code that you had, so I can only use the example of, the general name MRI. If it is provided at a hospital, it is the hospital's responsibility. It's billed to Medicare by the hospital. The ambulance transport is the hospital's responsibility. If it is provided at a freestanding diagnostic or a freestanding MRI center, it is the SNF's responsibility, and so is the ambulance run to that MRI because it is considered part of the MRI in the bundling concept. Okay, so we do have, again, the 5 major categories. Major category 1, exclusion, and I'll go through that one in just a moment. Major category 2, additional services, but they have to be rendered to specific beneficiaries. Major category 3, additional excluded by certain providers. Major category 4, additional excluded preventive services. And this one is interesting because these are the services that are Part B benefits that are not included in the SNF prospective payment system, but are still something that the SNF has to bill, or the swing bad. So while they may not be included in the prospective payment system, they are still included in the external provider billing the SNF. So hopefully that one makes sense. And then major category 5 is Part B services included, and this is those outpatient rehabilitation services. You can see they have a very specific revenue code that would go with it. So anything billed with those 3 revenue codes would represent the types of services. So hopefully all of that makes sense, but let's move a little bit further into it, and we'll talk a little bit more about the caveats. So another question that came in before I jump ahead into this is, what are these Part B files and when should you use them? Please remember they're for Part B services, professional services. They could be for an ambulance service, which doesn't meet the criteria under here, ambulance trip, which meets the criteria under one of these other categories. Again, we'll talk about that a little bit. That is the type of things that would be in the other file. Okay, so there's the 2 types of files. Please be sure, especially if you're doing something that has a professional and technical component, that you check both files, because that's where some of these come in, and the technical component would be included, but the professional component would not be included. So I don't want you to get stuck up saying, well, it says right here that it's included, and then the SNF says, well, we're not paying that. Medicare says we're not paying that. Check both. Let's move on and let's talk about major category 1. This should be hopefully your next slide. Major category 1, again, is interesting in that it is divided into subcategories, but the caveat that applies is always, again, that hospital has to be done in a hospital or critical access hospital only. If it's not, then it's included. So there we go. Also, it must be a Part A stay for these services. If it is a Part B stay, Medicare is no longer paying the room and board, you don't even need to go there. You need to say, oh, Part B, bill Medicare, done. Then what you would do is pick whatever the category of service is, and you would read about it. One of the big ones that we had questions on is this list. And the reason that it's an inclusion versus an exclusion, there are way less surgeries that a SNF is able to do than the ones that they are not able to do. So CMS did an inclusion list. We also had a question come in regarding emergency services, and I want to point out that they have to be using the revenue code 045X. If they are not using this revenue code, this does not apply. So if they bill it as an outpatient hospital service without that emergency code on it, that emergency room code, then this emergency services does not apply. So sometimes if it's billed in a different manner, then it would apply this. Okay, then it would apply to the bundling concept. It's really about looking for this 045X, revenue code 45X. And would you necessarily know that? Well, no, you may get a take back. You may get Medicare requesting money back because when it came in, they did not bill it as an emergency room service. Instead, they build it as some other type of service. So hopefully that helps you understand a little bit about the emergency service exception. Um, but remember that it is based in the billing, and it is based in how that facility bills it. The facility being the hospital or the emergency room facility in this case, not necessarily the SNF. The SNF gets kind of stuck into the ballgame because if it's not billed with that 45X rev code, then you got to bill it to the SNF, and the SNF is responsible for it. We had quite a few questions on ambulance services. Again, I've decided to teach a whole class on that. But in general, this is where it explains that you need to look up the procedure code. You need to know what's being billed for the end result, and then determine which category it falls into. And if it falls into category 1, A through E and G, or category 2A, then you bill Medicare. If it falls into anything else, then you bill the skilled nursing facility, and that also means category 1 being transported to a non-hospital. So not quite as easy and as quick, fast thinking there, but that'll kind of summarize it for you. Just again, additional surgeries. I'm going to skip through that one. Here we look at services excluded, and this is major category 2. What do you got to know? Keep in mind the first paragraph, we want to keep these 2 points in mind. The ambulance is associated with 2A, which is end-stage renal disease beneficiaries. Okay, not necessarily the hospice selection. So we don't want to include 2B, and that's from this paragraph right here. You can see 2A, not 2B. So when we look at the beneficiaries who have elected hospice and they're in a specific hospice program, they are excluded from SNF, PPS, and consolidated billing. But that's hospice-related bundling, a separate type of bundling. Don't get confused between the two. So there are times when a consolidated billing could apply for a non-hospice diagnosis. Lots of things going on with that, and that's what this 2B is kind of designed to explain. On the other hand, 2A is just about end-stage renal disease patients and when you want to make sure that there are certain procedure codes are billed, and then the treatment of that end-stage renal disease, which is what this just explains. But again, we're looking for a bill type 72X coming from a renal dialysis facility, okay, and then all the dialysis coding. But the key coding that we look for is the diagnosis code. If it doesn't meet those, then that's not going to work. And then if we look at EPO and RSNP, we want to look a little bit further in, and we just want to make sure we're differentiating, and you want to follow the guidance down here in these 2 sections of the internet-only manual. Moving on, I'm going to skip through the rest of that, and we're going to go to major category 3. Now remember, trips associated in major category 3 are not excluded for ambulance. So if it's within these chemotherapy or anything like that, this is not an exclusion. However, the chemotherapy is an exclusion and are excluded from consolidated billing. And then it gives us the caveats that go with that. And so if we were to look at the list, this list, we will see that these would be the procedure codes listed in major category 3. So there we go. And then the last one is preventive and screening, or the next one is preventive and screening. I've already talked a lot about this, but I just want to remind everyone that preventive and screening for skilled nursing facility prospective payment system would be included in this, or would be included in the SNF payment, but not their prospective payment system payment. And you want to make sure it's billed accordingly on the right type of bill. Okay. Puzzles that right there. And that just talks about the different services. Last are the Part B services that are always included. And again, these are your therapy, your outpatient rehabilitation therapy revenue codes. So what does that look like in terms of the actual Excel sheet? Now we've already looked at it again. I just gave you a quick peek again. Go ahead and do this. Someone asked, what I find to be the fastest way, please put a filter on it. Come up to your top row. Oh, I already have a filter applied, but apply a filter, use this and just search for your revenue code. So if you're going to say, I want an A04425, okay, there's my revenue code. Yep, here we go. Ambulance ground mileage is included, but it does have the caveats because it is a major category 1H. That's how we would use that. You can use it for any particular revenue code, procedure code, whether it's a HCPCS or procedure that you want, a CPT code, feel free to do that. All right, let's go ahead and move back to the PowerPoint, which means it's question and answer time. Karen, do we have anything in chat?
We do not have anything in chat at this time.
Okay, so let me go through a couple of them that I have not already covered. Um, so they want to know how to bill when a patient comes from the SNF to an outpatient diagnostic center or a screening. The key thing to remember is it's going to be billed back to the SNF, so you have to follow their guidelines. Now, if that same service was done at a hospital and it's on major category 1 for any reason, then you're going to bill Medicare following the Medicare guidelines. If you need more information, let me know. What Part B services is the SNF responsible for when the patient is in a SNF? Well, keep in mind, Part B services for the most part would be separate. And we say that because we're talking about outpatient services, professional services. I do not want you to think supplier services. Supplier services, for the most part, are not separate, and they are still a Part B service, but they fall into the bundling category, caveat. So professional versus suppliers. And it does make a big difference when you talk about Part B services. And then you do have to go back and know the the procedure code, diagnosis codes, and check that out. I did show you where to check for updates, but again, remember to go to the CMS website. You want to make sure you're aware of when the update took effect. The next one is, how do you get a company to pay, a skilled nursing facility to pay your charges? We are not allowed to answer that question. That is a legal question. The reason for it is it's in the Code of Federal Regulations. It's under their conditions of Medicare payment. It is in Title 42, Chapter 4, Chapter B, Part 424. I had Karen put a link because I don't want to have to repeat that. But take it out. If you need to, it is something you'll have to consult a legal counsel. It's just the same process. Okay. One person asked if a Part A stay can be retroactively rescinded, and absolutely this can happen. The Part A stay that can be retroactively rescinded is the patient's inpatient hospital stay. It is a Part A to be rebill, and it does occur. This means that the Part A hospital stay was not medically necessary, but upon post-payment review or after the patient was discharged or review, which means that it affects the direct payment of a skilled nursing facility stay. Remember, they have to have that 3-day qualifying stay. So there's a variety of factors that can go into that. Again, if you want more information on that, put that into the chat and we will get you that. Okay, let's move on. Certificate of Achievement. I'm going to have an email coming out to you real quick here, and the email is going to contain a survey link, which is important. But even more important, you asked me about how do you get training, CEUs. We don't offer CEUs. However, your governing bodies do. What they need is the certificate that's in that email on the bottom. And you want to make sure that you get it because it has contact hours. Contact hours are what they use to base their CEUs on. Some of them will ask for a PowerPoint presentation. Again, you can download that on our website. If you have follow-up questions, I will take them for 7 days. Follow-up questions or comments also does include, I called in, I did not use the computer, and I need a certificate. However, when you do that, I do need a direct phone number. Without that phone number, I will not give you a certificate. So please make sure that you're giving us that information. Follow the directions in the chat. Karen did put SNF Consolidated Billing Facility Services. Great. Put that in the subject line and help me out understand. Again, if you have a claim-specific question, please contact customer service. Survey. Seven, talk about this. Please take time to complete the survey. Karen gave you a link in the chat. I've shown you that it's going to come to you in the follow-up email, but it's so important that even after the fact, I'm going to give you the survey again, and I'm going to give it to you in a pop-up box. It's going to have a little triangle on the top and next to the external site. We are telling you that the CMS Mac Fed ramp, which is the first part of the web address, this means it's the survey. If you notice, that's what Karen just gave you. Please take the survey. I want survey feedback so bad that if you're listening to this as an encore presentation, I'm going to give you at the end a box that looks like this and it says online survey. If you select that, it's going to take you to the survey as well. Please provide the survey feedback. Another thing, the survey is where you're going to give us suggestions, whether related to consolidated billing or not. You're going to give us the suggestions for what you want in future education. So we really do want to hear from that as well. That's it. That's all I got, y'all. So thank you for attending. I hope you have a great rest of your day. Please remember to complete that survey. We really do encourage you to do that. Give us all of that. Also, please remember this will be posted within the next few days as our Encore playlist and then into our Encore presentation. So on behalf of myself and Karen, I hope that you found the education information helpful. We look forward to your survey comments and hope that you'll join us for future education. Thanks, everybody. You can disconnect.